Good evening once again, and welcome to another Doctor on Call program. It is a pleasure, as always, to be here on a Tuesday evening to share information with you. And tonight, we have a very important program. In fact, we have representatives from the Grenada Planned Parenthood Association, and we will be discussing a number of things, starting with the Build Back Equal project, and we're going to hear all about that. We've got quite a number of people in studio with us this evening, I think about 5, so we have a lot to share. And of course, before we start, we welcome all our viewers on GBN television, our friends on our Facebook page and YouTube channel, and also our listeners on K105 FM. So I'll tell you, before we get into our discussion, I'll ask our guests to just take a minute or 30 seconds to introduce themselves and probably share with us about their association with the GPPA. So it's a good time to welcome them all. I see we have Miss John, Dr. Fletcher is with us, Miss Gooding, and Miss Bruno. Wow, I'm surrounded by loads of wonderful ladies this evening. Am I lucky? I think I am. But we should be joined by a gentleman a little later on, maybe about 9 o'clock. So, of course, we will have a good time as always. And a little later on in the program, we will open more telephone lines to engage with you, our listeners. If you have any questions that you would like to ask or contribute in some other way, we'll be happy to have you. So let's start with Dr. Fletcher. Dr. Fletcher, good evening and welcome to Doctor and Call.
Good evening. I am, like you just said, Dr. Nakosha Fletcher, and I am attached to the Grenada Planned Parenthood Association. I am the physician there, and very happy to be on tonight with you and some very important YAM members who will now introduce themselves.
Right, and we can start with Zerika.
Good night. My name is Zerika John, and I am the Public Relation Officer of the Youth Advocacy Movement, GPAM.
Lovely. We also have Miss Gooding with us. Miss Gooding.
Hi everyone, my name is Eloise Mitchell Gooden, and I am a member of the Media and Public Relations team of the Youth Advocacy Movement at GPPA.
Lovely. And finally, for the time being, Ms. Bruno.
Hello, good night everyone. My name is Judah Bruno, and I am also a member of the Media and Public Relations team of the Grenada Planned Parenthood Association.
Oh, thank you. So, ladies, welcome. It is a pleasure to have you on the program this evening, and I'm looking forward to a very engaging conversation. So, we're going to start with the Build Back Equal project. In fact, I heard it in the news, but not too familiar with it, so I'm happy you're here so that we can all learn. So, Dr. Fletcher, you're gonna go with this one. To open, tell us what it's all about, the Build Back Equal project, what it is, and share with us some information regarding that.
All right. So the Build Back Equal project, and I'm happy you heard about it. It means it's out there and persons are aware that there's something going on. But what this is, it is we say a multi-year. It runs for, I think it's about 3 or so years, but a multi-year, multinational, so it's throughout different countries. But it's a project that focuses a lot on sexual and reproductive health, getting into schools, comprehensive sexual education. It looks at gender equality, which is very important as well. But all of these very important aspects, and we're focusing as well, all of these services on young women, young people rather, adolescents, the disabled, or rather, because we try to steer clear of disabled, but differently abled women. So this is our target population, and these are some of the topics topics that we're really honing in on. Now, this is funded primarily by Global Affairs Canada. So that's where all of the funding comes from. And we have a lot of implementing partners. So UNFPA, for instance, or UN Women, along with the Grenada Planned Parenthood Association, implementing different projects so that we achieve these different goals in this target population.
Wonderful. But what's the goal, the real goal of the project? What does it aim to do? What do you hope to achieve?
Well, without oversimplifying it, I hope, and of course the YAM members can always jump in, but really to empower women. So I just mentioned women, adolescents, differently abled persons, to empower them. It focuses a lot on economics and enabling persons financially, but through small businesses. So we have some financing access, skills training. I also mentioned that, and of course that's where I'm mostly involved in or with, but the availability and accessibility to healthcare services, sexual and reproductive services. And what the YAM would talk at length about is the youth advocacy movement really engaging and, like I said, empowering youth, their own colleagues, their peers. So they've been doing a lot of projects reaching out persons of their own age group together and really enlightening them. I had a 16-year-old tell me a couple weeks ago, had it not been for some of these initiatives, she was embarrassed to say how little she knew about sexual and reproductive health. Mm-hmm. So it really is getting that information out there and empowering these persons. So I'd say that is our top goal, but empowering these populations through these different initiatives.
Right, lovely. I need to find out about the GPPA's role in that, but before we get there, sexual and reproductive health. We do hear that quite a lot. But when we speak of that, what do we mean, really?
Well, it is, and it really is a very all-encompassing term. So it's a very broad term. But this is where we start talking about chlamydia. And, I think I keep mentioning the rise that we've had on island. I know a couple months ago, Ministry of Health sent a notice out that there was indeed a rise in sexually transmitted infections. So the testing and, like I said, management, some of these are curable, others are not, but we can manage the symptoms. In addition to that, we talk a lot about cancer prevention, breast cancer, cervical cancer. All of this comes under that sexual and reproductive health. So in the way of cervical cancer, pap smear, that is one of our biggest, I'd say, numbers-wise. When we look at the numbers, it's what we do most. But frequent pap smears, because that allows women to catch something early enough so that we can address it. Of course, the breast exams. We did quite a few breast exams in October because that was Breast Cancer Awareness Month, encouraging women to do ultrasounds and mammograms. In addition to that, we do a lot of prenatal, antenatal. All of these come under sexual and reproductive health. We talk about, fertility. Some patients come in and, anything that we're not able to do as well within the association, we refer, but it really does cover a wide range of services. So counseling. I don't want, I'm talking a lot about specific services, but just sitting, talking to patients. We do that quite a lot. Contraceptives, and we'll get into that in a little bit, but letting women know, having them become aware of all of the options of contraceptives available to them and choosing what works best for them. You know, unwanted pregnancies is something that we want to see those numbers come down drastically. Every pregnancy should be wanted and planned. So access to contraceptives, that is something that we are very, very passionate about as well. And this, you know, they can get quite expensive, but again, just keeping the prices at a minimum to increase that access. Under sexual and reproductive health.
Right. Dr. Fletcher, I want to jump forward a bit before I come back to you. And I want to bring in Ms. John here because there are a couple of things you mentioned as it relates to sexual and reproductive health. And you mentioned a couple conditions and infections that can, you know, step in and so on. But it's important that we have so many young people involved because I think this is very critical. For example, a young person coming down or picking up an STD can make them very uncomfortable in coming forward to say, look, I have this, I want to get rid of it. And I've heard some strange stories about that where people, men, women, because of, you know, discomfort and uneasiness, they have not come forward because they just can't deal with it. Ms. John,
Yes.
From Yam's perspective, how would you deal with young people in getting them to come forward? Because a lot of these, as Dr. Fletcher said, a lot of these conditions or diseases, they are curable. I mean, you can deal with them. Medicine has come an extremely long way, but the discomfort remains. So as a group of young people, how would you encourage your peers to, look, don't feel uncomfortable? Because if we don't know, we can't help you. How do you encourage them to come forward to deal with that?
Well, you may know now is a very techno-savvy world, and we try to promote that our office is quite confidential. It provides a safe space for any adolescents that they can come and feel secure. We also provide information on different topics such as the IUD or the JADA. We post stuff, the benefits, the side effects, and I think this gives them a little courage and a little security because they know the service that we provide. They have a little insight, and of course, well, they can come see for themselves that when you come to GPP office, it's quite confidential and it's safe and it's great.
So, have you seen, let's say, for example, a reduction in the discomfort involved in young people coming forward to get themselves sorted out? You know, in cases where it's present.
It has times where I do hear that some adolescents do shy away, but sometimes, like, I try to encourage them, tell them the benefits, and primarily sometimes it's from parental supervision. So they'll be like, oh, I'm scared my parents will say this, but we try to encourage them to check out their health, because being healthy is quite very important to you. And yes.
Okay, lovely. Dr. Fletcher, let me just come back to you. As a physician, and I'm sure you've come across numerous cases like that. How is it for you as a physician communicating with a patient and making them comfortable and get them to understand that, look, this is not something you need to be ashamed of, but it is a way of getting yourself sorted out, getting you back on track so that you can go back to your normal life and probably do what you enjoy, maybe just in a safe way. How do you deal with it?
A lot of patients come in and they are very apprehensive to begin with. And I say, so why are we, and the receptionist at the front, she usually asks them what they're here for, and they may just say some testing. So they come in, and of course, if you don't want to say that at the front, that's completely fine as well. But there's always some degree of apprehension. And like Ms. John was just alluding to, it is reassuring them that this is confidential, one, but there's no judgment here. And I think that's just big. Talk to me. Just let me know what's happening. Nothing. I said to a patient today, if you hear anything outside, you said it to someone. You're going to have to try to remember when you said it, but you said it. So very, very confidential, and making that environment comfortable. So we're just chatting. We are that might be hard for some people to do. But I am a friend, I'm a co-worker, I'm a colleague. Let's just chat about this. And I see the layers peel off a lot of the time as we're going along. Sometimes, they say, Doc, it's just routine testing. I'm fine. I don't have any symptoms. And again, that reassurance and that comfort. You can tell me anything. You realize you go from routine testing to, I did notice I had this symptom. So I see it all the time. But it really is building that rapport, because you see the difference. From the minute that person feels, I could talk to her, that is when they really start saying, Doc, I've been so careful all the time. This one time, and here I am. How did this happen to me? But building that rapport, and I think I've done it for a little while now. And, you're not supposed to blow your own horn. But I think we're good at what we do.
Of course, I do believe. But let me ask though, on the issue of gender, sometimes when you hear about the GPPA, and I know in olden days people would just simply refer to it as family planning, the kind of Grenada cultural name, right? But you think women, for whatever reason, you tend to think women. Do you get males coming into you to deal with these problems as well?
I do.
Excellent. Yeah.
I'm happy that you asked that. Now, certainly, the numbers are significantly less.
Yeah.
We do see a lot more females. But every time, especially a young man, and we see, I would tell you, from 17, 18, I had a 17-year-old a week and a half come in with his parents, but we see from 17 to 17, But I commend every male, especially, who walks through that door, because we know how stubborn males can get.
Oh, yeah.
I'm hoping, you know what I'm hoping? I'm hoping you're not in the same position.
Oh, no. In fact, I was going to ask you, in terms of because I'm trying to, put all of that into perspective here. Your staffing, I kind of get the feel it's predominantly female.
It is, in fact.
So could that be a deterrent for our men?
It might be. You're right. It may be. Although, you hear the average man say, had it been a male nurse or a male doctor, I would not. Because you see, especially with the STI testing, we have to get samples.
Right.
And they feel less comfortable with a male in some cases. But it is predominantly female. In fact, we have our first male executive director. So we moved in the right direction.
Yeah. You're bridging the gender gap.
But just like I would say with the patients, certainly more females on staff. But that is something to consider. consider. Whereas it certainly works for, in some cases, I don't think it can work against for some males. So maybe we need to have a male nurse come in on certain days and see what it must look like.
Yeah. So let me just move down and bringing our media folks in the discussion. Miss Gooding and the other one, where did she go? Miss Bruno. Miss Bruno, where did you disappear to? So
I'm here.
Okay, lovely. So as it relates to the GPPA and its role in the Build Back Equal project, let's talk a little bit about your responsibilities and how you get things going to put the word out there. Ms. Gooding, we start with you.
Okay, so the Build Back Equal project, so it's generally implemented in partnership with agencies like UNFPA and UN Women, as aforementioned. So the youth advocacy movement's role in the Build Back Equal project is one for youth-led advocacy and education. So we act as the direct link to the youth population. We carry out the critical education and informational aspects of the project. So it aligns perfectly with the goals of the Build Back Equal project. And then we also ensure that young people like ourselves have easy access to sexual reproductive health education. So we are basically, like I said, the link that reaches adolescents in hard to reach areas and communities, such as when we do our booths and the Sofa Talk series that will be mentioned later. So with this information about GBV, SRHR, so we act as the avenue for that information to be spread in hard to reach areas or even easy to reach areas, just so every adolescent has an equal opportunity to reach that education. And then additionally, community engagement as outreach, like I just said, actively and even continuously involved in community-based initiatives, piloting comprehensive education in remote areas and accessible areas, just wherever you can find people. We're trying to get ourselves out there to push the BBE project.
Okay.
And then lastly and most importantly, as the media team is very on par, amplifying youth voices. So our representatives participate in project meetings, showcasing our work and the importance of youth involvement and inclusivity in policy and in every area that you can find CSE and sexual and reproductive health education.
Okay, wonderful. So, Ms. Bruno, we're going to bring you in here. And I do know that there are quite a number of activities and, other engagements that you're involved in. Share some of those with us, and maybe you can tell us why some of these activities and programs were developed.
Okay, so some of the activities that we engage in are stuff like community outreaches, having different booths at certain health seminars. We also actually have a few of our first TV series type of podcast thing we have going on called Sofa Talks, which is a bold, engaging 10-part series that dives into the real life issues surrounding comprehensive sexuality education for adolescents. So throughout the series, we explore topics such as consent, healthy relationships, gender equality, body autonomy, and more. So this happens all throughout open, respectful, youth-led discussions, and we have PTA engagements because we're trying to get the parents involved. So because a lot of parents hold their children close to them, so we want to be able to get to them. So we also want to reach out to the parents to let them know what we're doing. So it's not just a oh, let's just talk to the children alone and the parents are out of the loop. We want to get them engaged because if we're educating the children, we want to educate the parents as well, so that everyone, not just the youths, but our whole country as a whole gets the information that we're sharing out. We also, yes, like I said, do the booths and just go around even through town. Like sometimes we would just walk and share information by word of mouth. We speak to people that we meet on the street, like ask them, hey, do you know about our clinic? Like we have such and such available. Or we often also incorporate mental health, like telling them like, hey, we have this helpline that is available to the public for you to call if you or anyone needs any sort of assistance, whether it be with to reach out to the public. And as a media team, as Eloise said, we make social media posts educating the youth. We often tell them that, hey, you could also message us your questions, or so if you want to be anonymous, you can message us. When we have booths, and so we tell them to speak up, but if they are still like feeling a little shy, we have anonymous documents where they could put their questions or so to come to us. So we just want any way possible to get the accurate information to them.
Okay, lovely. So, Ms. John, I'm coming back to you. And we heard from Eloise and we heard from Ms. Bruno regarding the sofa talks and PTA engagements. How successful have they been thus far? Are you able to make good grounds? Have you been able to get feedback? And, what kind of feedback? Are they positive, negative? What's the reaction to the people who you engage? I think you're still muted. Yeah.
Sorry.
No problem. That's all right. Yeah, that's all right. Yeah.
Okay, so actually 2 of our sofa talks have been aired on GIS YouTube and also on our YouTube page, Grenada Planned Parenthood Youth Advocacy Movement, YAM, and it has been really good. A lot of people have told me it has been very informative. Some stuff they didn't know, it was really great, like it was very enthusiastic. So, and the presentations, it was very youthful, wasn't boring. And for PTAs, so we have went to different schools all around Grenada. Think about 8 or 10. I'm not so sure, but it's a lot.
Right.
And thus far, it has been really positive. And bring back to Sofa Talks. During the production, the first episode, it didn't really have that much people, but it has some, as a episodes increase went on, more students became to come, and it was really good. It was a really good initiative.
So interest is definitely building.
Yes, most definitely. Parents has been telling us it's great to see young people empowering, advocating, and it has been a really good experience.
Oh, that's lovely. That's lovely. Okay, so we're going to take a very short break. When we come back, I think the gentleman has joined us, and so we are going to engage him. So we take a short break, and we will be right back. Stay with us, folks. Don't go anywhere.
Have you heard about the new Softweave bathroom tissue with total hygiene? As hygiene and safety have taken center stage, our bathroom tissue is now manufactured with 3 different technologies to offer the best protection for you and your family. UVC light technology for a safe and effective disinfection process, eliminating 99.9% of microorganisms. Also, production at high temperatures, killing all types of germs and bacteria. And it's pH controlled with delicate fibers to prevent irritation for even sensitive skin. Softweave Total Hygiene Bathroom Tissue, available in supermarkets and shops island-wide. Visit Softweave Caribbean Facebook or Instagram pages for more information.
Are you looking for a reliable, affordable, and customer-friendly pharmacy? Look no further than Hills and Valley Pharmacy, the nation's leading healthcare products and services provider. We are committed to serving you at convenient locations. Find an extensive and affordable selection of prescription and over-the-counter drugs and medical supplies at Church Street, Hillsborough, Carriacou, Jubilee Street, Grenville, St. Andrew, near the bus terminal, and Halifax and Grenville Street, St. George. Our committed team is always available to offer valuable assistance for managing your health and wellness. Discover the additional benefits of our wholesale distribution on Halifax Street and our Medcare Center on Grenville Street, where we provide in-house physiotherapy, massage therapy, doctor consultations, and eye care services. Our commitment is to satisfy all your healthcare needs, including competitive prices, loyalty rewards, and special discounts for seniors. Contact us at 435-6904 and WhatsApp 535-4734. Choose Hills and Valley Pharmacy. Remember, your health is our business.
Distributed by Echo Blue Limited. Visit us on the Lansopine Main Road or call 405-4818.
Asian Spa and Wellness Cafe, nestled in the serene surroundings of Le Bleu, Calivini Bay, St. George, is the perfect spot to unwind and relax after a stressful event or when you wish to spoil yourself in the most comfortable and relaxing atmosphere. They offer many different massage modalities, including thigh hammer, washer and cupping, signature thigh deep tissue massage, also facials to depuff and tighten pores, deep cleanse full body, hair and nail treatments and more. Take a walk down to the cafe for authentic Thai breakfasts and delicious traditional dishes. Choose from our special mixed drinks, both hot and cold. Opens daily. Visit Asian Spa and Wellness Cafe today, Le Bleu, Calivini Bay, St. George, because you will not regret you did.
At Oasis Pet and Garden, we bring you the best products at the best prices nationwide. Pet lovers, we have a wide variety of loving, healthy pets just for you. Hamsters, guinea pigs, fishes, birds, puppies, bird food, and dog food. Visit the Oasis Pet and Garden today. Conveniently located along the Wester Hall Main Road, Wester Hall, St. David's, and Melville Street, St. George's. Now serving you at 2 locations. Visit us today.
Welcome back, everyone. We're talking to the representatives from the Grenada Planned Parenthood Association. Our focus this evening weighs heavily on the Build Back Better project. Sorry, what am I saying? I think my mind is somewhere else. The Build Back Equal project. Yeah, that's it. I think I got it right this time. And we would love to welcome Mr. Fred Nunes. I think have I gotten it right? Okay, lovely. Welcome to the program. We're happy to have you. And we will engage you in a bit, but I just want to go back to Dr. Fletcher for a moment. And Doc, earlier you mentioned about lax. So let's talk a little bit about that. What is it, and what does it involve? Tell us a bit about that.
I missed you for a second there, Godfrey. So you asked me to tell you a bit about.
No, not yet. I was going to Dr. Fletcher first. Yeah, I'm coming to you shortly. So Dr. Fletcher, let's talk about the lax.
Right. So I missed you, I think, just as Fred might have. So we weren't sure who that question, what the question was, one, and two, who it went to. Right. Yes. So LARC, now this is LARC, LARCs, and this means or stands for long-acting reversible contraceptives. Now, as the name would suggest, and it's like you said a while ago, once upon a time, GPPA, Grenada Planned Parenthood, where are you talking about? You tell somebody family planning, and you know what they're referring to. So when we talk family planning, we're talking the birth control. And remember, I always want to reiterate, we don't want to stop persons from having children at all, but it is planning pregnancies, like I would have referred to earlier. We don't want any unwanted pregnancies, but wanted and planned pregnancies. So spaced pregnancies as well. You know, we say that 2 years, that's a good time between pregnancies, for instance. So it is sitting with patients informed and best decisions for them. These locks they are long acting, like we said. So longer acting when we compare them to others, and I'll get into a little bit more detail, but reversible, because we know that there are some irreversible methods as well of contraception. So longer acting than others and reversible compared to irreversible options. So without getting into too much of the medicine, we can talk about the injection, which a lot of people are familiar with. Now, these injections, patients have to come back in every couple months. We do have a 1 month, a 2 month, and a 3 month injection. But there are a lot of persons who tell you, Doc, you know, it's a little bit inconvenient for me to come back in every 3 months to get this. I come back in late more often than I should because I'm busy at work. I forget sometimes. The tabs, I hear the same thing all the time. We have oral tabs. Now, you have to take these tablets every day, ideally at the same time every day. Now, more patients than not say, Doc, I'm not going to do that. I can be open and honest with you, and it won't happen. So compared to these short-acting methods, these longer-acting methods last 5 and 10 years. So we insert the method in clinic, and without having to remember to come back in or to take a tablet every day, our patient is protected against unwanted pregnancies. So these are the long-acting reversible. Now, to stress on the reversible, if a patient decides after having a method that could last 5 years, 2 years into it, that she's no longer interested, or she's met someone that settled down, she wants to get pregnant, very easily reversible.
Okay.
So these are the characteristics of these LARCs.
Right. In terms of effectiveness, because with everything, there's usually the rare occasion or the possibility where something can slip through the crack. Any of these cracks with the locks?
Well, these are the most effective of all of our contraceptives. So over 99 or more than 99% effective. Now, I would say there's some implants, and they are the size of a matchstick, and we insert them in the arm. Now, these, for instance, they don't tend to move and so. Very, very effective. Now, the one thing I would mention, because I don't want anyone listening saying, well, but I heard this, and Doc failed to mention it. But with the IUDs, so the implants and IUDs are the two LARCs, very, very rarely you can have an IUD move. But again, all of that is part of the counseling. So we let the patient know what symptoms to look for and come in as soon as that happens so that we can remove it and have another one placed. But what tends to happen too, because remember, this is in the uterus. So if the patient has a very heavy bleed sometimes, or a lot of uterine contractions, we can get some Very small movement. Yeah. So we understand why it happens, but like I said, extremely rare that we see this. And once the patient comes in, we deal with that. But like I said, most effective method.
Okay, wonderful. Any side effects? Anything that patients should be concerned about, or with insertion? Usually people tend to be a little uncomfortable when things are inserted. Does it come with any kind of discomfort, pain, anything like that?
Yes. Well, and before I even say that, I would say, of course, the effectiveness as well has a lot to do with the fact that you insert it and forget it, right? You're not remembering the tablet. But the insertion process, now for the implants, we numb the area. So the patient feels that very initial insertion of the needle and not a thing thereafter. I've had so many patients say, "Doc, you're done." No, the IUD is slightly different because, like you said, there is some degree of discomfort, I'd say. Just like the pap smear, when we insert the speculum, a lot of women say, "Doc, I don't touch." So there is some degree of discomfort, but very little pain. And of course, we have different thresholds for pain. So if someone books in advance, sometimes I tell them they can take some ibuprofen before the procedure. But I think what I want people to take home is that, yes, I admit to some degree of discomfort, very little, if any, pain at all.
Okay, wonderful.
And very short-lived, because the procedure is quite quick, very, very quickly. We, again, just like the implants, some persons ask, "You're finished already?" But the procedure, short time, and even afterwards, you may have very minimal cramping and so, but a lot of persons liken it to just mild monthly cramps that they have.
Right.
So I don't ever want persons to hear the horror stories and be deterred.
Right.
Yes.
What about during intercourse? Any discomfort there at all?
No, none at all. Of course, again with the implants, remember they're in the arm, so you forget them entirely. And with the IUDs, there's some strings. There are 2 strings that hang out of the cervix, right? So not out of the vagina, but out of the cervix. And these are there because that's what we need to remove.
Right.
But over time as well, I always tell patients it's like leaving spaghetti in a glass of water. It softens and just curls up. So you really do forget that it's there.
Okay.
No discomfort.
Okay, wonderful. But with that level of effectiveness, why isn't it more widely considered than the regular stuff that people use?
That's right.
You hear a lot. In fact, one of the things I hear quite a lot, especially with women, you hear about the morning after pill.
Correct.
It seems to be a very popular thing. But with the level of effectiveness of LAX, why isn't it more widely used? Is it a case where Zarica and Eloise and Jodelle is not doing enough? Just teasing there. Yeah.
And they're probably side-eyeing us. But we are certainly going to be doing more work because I do think it comes down to awareness. And, that is where that BBE comes in, like we said. So I reiterated the education, the empowerment. I mean, just sitting and empowering young people and women. You have these options. Use them, utilize them. But education and persons just being aware. I think So many people still think when you hear family planning, birth control, it's the injection, not realizing that we're talking about tablets, injections, implants, IUDs, the range is so wide. But I think we need to do a little bit more when it comes to the awareness.
Okay.
And once we do that, I think it will take off because it's even more cost effective.
Right.
Looked at the cost of doing that injection every 3 months compared to putting in a method for 10 years. The price is a fraction of the injections.
And so, also considering if you want to remove it within that time, you can just do that, all right?
Correct. Exactly. So most effective, and I really do think, and of course I'm on board. I want us to get out there, get the information out there, and have women take charge and make these decisions.
Very important. So I need to have you on the program a little more often, yeah?
I think so. I want to get sick of hearing it.
I agree. I totally agree. So we need to take this discussion to a different level. But just before we do that, let me bring in our YAM folks. Anything you want to add to what Doc said regarding the locks and the awareness, and before we go to Fred?
Okay, so I would say when it comes to the locks and so, obviously those would be more catered toward the adults because they have the decision as they are, their brains fully developed and they're of legal age to make the decision whether they want to take those things or not. But as YAM, as Youth Advocacy Movement, we educate our younger generation or our generation on those sorts of methods so that they know that it's there available for them when they reach the stage where they can make those decisions whether they want to or not. So we just spreading information, so destigmatizing them, like making them know that, hey, this is available to you, but it's not anything that's like nasty or strange or anything. It's just another form of medication that you can use to protect yourself from pregnancy, and so just educating them.
Right. Eloise, anything you want to add?
I would just like to implore anyone who's listening or who's heard something from one of our sessions, or just like anything they've heard about LARCs and other contraceptive methods, I want to implore you to do a lot of research before jumping into a decision such as that, because even if by air it seems like a simple process to get it done, I think that it's necessary to take the time to do your own research and to talk to someone about it. We have lovely Dr. Fletcher and other professionals who would be able to give you better advice, but it's not a decision to just, although it's easy and effective, it persons who may be listening. As a young person myself, I'm saying youth to youth to take the time to do your own research.
Okay, lovely. And Zarika,
also I love to add on Eloise and Jodel's note. Long at LARCs, contraceptives, it doesn't prevent from STIs. So we ought, if you are sexually active, to use condoms. And it also doesn't cause infertility. I hear a stigma with that. So it doesn't do that. So if you are sexually active, we do advocate the ages of 6, once you have consent, that you do protect yourself. Thank you.
Right, lovely. Very important, very important, very important. So, Fred, it's time to bring you into the discussion. An issue that has, made the wrongs in Grenada. It has created all sorts of conversations here and there. The age of civil responsibility, that bill, which did create quite, some conversation. So let's talk about that. What is the age of civil responsibility bill? Let's talk about that. Let's put some, additional clarity to what we've heard thus far.
Okay, so Godfrey, I'm going to go there, but there are a couple of things that I've heard while I was waiting, which I would like to comment on.
First sure, definitely.
You and I are in a minority situation this evening.
Well, I highlighted, that was the first thing I highlighted. I couldn't wait for you to come on because... yes.
I want to link that to the discussion you had about gender and to the discussion you've just had about larks. One, the most effective long-term contraceptive is, in fact, a vasectomy.
Right.
It is cheaper. It is more effective. It has far fewer consequences, complications, almost none, in fact. And it is more reliable than a tubal ligation. I repeat that. It is more reliable than a tubal ligation.
Right.
But when we talk about gender bias, know that medical students are routinely taught how to do tubal ligations. They're not taught about how to do vasectomies. So institutionally, there is a bias against male engagement, which is an absurdity since the record for a woman in terms of fertility, the record is between 44 and 68, number of children she could have, right? The record for a man is over 1,000. So if we're interested in family planning, it is incredibly stupid for us to be focused on women.
Only.
Let me give you an example of the measure of the bias. I did some work here. There were 300 tubal ligations at Queen Elizabeth Hospital in Barbados. There was one vasectomy. So, you're talking about a ratio of 300 to 1. That's the kind of absurdity. The other thing I would like to add in terms of what Nkosha mentioned earlier is that when we talk about the reliability of contraceptives being 99%, that's 99% for year one. By the time you get out to 10 years, it's a 10% problem, not a 1% phenomenon. So the reliability, we need to be mindful that the risk is much larger than the so-called advertised risk. Okay? So those are the links I wanted to make between gender, long-acting, and the institutional bias that we have about not educating people about male responsibility and the male role.
Right. So just before we move on, let me just go back a little bit. And you mentioned two things here, the vasectomy and the tubal ligations. And there are people listening out there, and they're probably wondering, what's this? What's this vasectomy he's talking about? Can you just break it down a little bit for the benefit of...
Sure. So I have had a vasectomy, right? It has not affected my virility in any way. A vasectomy is not a castration. Just as in a tubal ligation there are tubes, so in the man there are vas, called vas deferens. Not a vas difference, but vas deferens.
Yes.
And they take the semen from storage into the penis. And all that a vasectomy is a snip. You move, make a slight incision. In fact, in some instances, you don't even do it. And you tie them off. It doesn't even require a surgical theater. I had my vasectomy in lunchtime, and I went back to work.
Right.
And the paperwork was downside more involving and time consuming than the procedure. It's a very, very simple thing. The trick about it, however, is for about 12 weeks after that, you need to continue to use some other form of birth control, whether it is a condom or your partner has to be using something else, because if you can believe it, it takes at least 12 weeks to empty all the active semen.
Okay.
And then after that, you are as clean as a whistle, my friend, and your name can't call with any problem. Okay.
But that being said, and you know, just putting it out there, what happens, because you said that with a slight incision and then that is tied, does the body continues to produce semen?
Yes.
And what happens to that? Yeah.
It continues to produce it, but it can't get access to the penis.
Right.
So it produces it, and it is consumed like any other cell in your body that is wasted and consumed.
Right. Okay, great. And finally, does it in any way interfere with the man's ability to have an erection? And I'm asking that because generally, after an orgasm, the penis tends to get back to its flaccid state.
Yeah.
All right.
Yeah.
Which sort of might indicate that there's something to do with the coming out of the semen and the erection. So what happens here?
There is absolutely no difference. In fact, I can't advertise, I can't brag, not at my age, it doesn't matter anymore. But my performance was better after my vasectomy.
Okay.
Because you still ejaculate.
Right.
It's just that the ejaculate is not fertile.
Okay.
It does not have any active semen in it.
Right.
But I'm not being funny when I say performance improves, because you are confident that you cannot create an unwanted pregnancy. So that mere relief makes things easier for you.
Right. Okay. Great. Lovely. So we get it out of the way. Let's go to that the ACR.
Okay. Can you let me share screen?
We can try. What I'm not sure is whether or not it may go onto the television. But let's try. Let's try.
No, it should.
Yeah, it should.
If you can see my face, it should, because what I have to share is a lot more interesting than my face.
Okay, lovely. So let's go for it.
Okay, I think I got it now.
Okay, lovely. Let's see. Right. Yes.
Can you see the screen?
Yes.
Okay, beautiful.
Yes, lovely.
Okay. So, Godfrey, what I want to do is just show some images and some data fairly quickly to address the ACR. So, why do we need this thing? Why do we need to talk about it? To begin with, we are not talking about a level playing field. I want to make this really, really clear. What we have is a phenomenon of men 20 years and older exploiting little girls. And the ACR is an approach to make the field less uneven. Okay? The next thing I want to show you is that this is the extent of the unevenness. Only about 5 to 11% of parents in the Caribbean speak to their children about sex. So we talk about parental rights, but really and truly, we should be talking about parental duties and parental responsibilities. And what you have here is a clear avoidance on the part of our culture of discussing sex with our children. And for those who do discuss it, those few parents who do, it's often tick the box, one discussion, and you move on. So it's not educational. The other thing we need to see here is that 80% of what we call teal pregnancies are by men 20 years and older. 55% of them, brother, are between men 20 and 24. So it's a real uneven playing field. This is not an even playing field, and this is not about romance. This is about power. So we are a minority, even in the whole population, but we have disproportionate power, and we abuse that power. This chart, I think, is particularly interesting, and I will relate to this in terms of the ACR. The ACR is saying what? Gee, we will move the age from 18 to 16, right? Mm-hmm. At 16, if you see where if you can see my
cursor, yes, yeah, we're seeing it, yeah. Mm-hmm.
Having sex. So if you go down to 14, 15, it is already at 29%. Why are we not including them in the ACR, right? Why are we waiting? As you can see here, the blue line is showing you the age at which teenagers have first sex. And by the way, let us not confuse first sex with voluntary first sex. Mm-hmm. Because something of the order of 42 or more, 43% of those first encounters are coercive. So it's not a matter of choice. Mm-hmm. You see here that the first pregnancy begins about 10, 13. But they're not going to clinics until they're like 16. That's madness. If we are to address the problem of reproductive health, we need to open it up much, much lower. And by the way, if this sounds alarming to you, this is just public health. In Guyana, there is no requirement for age with respect to HIV testing. A child of any age can walk into a clinic and get tested for HIV. That is in the best interest of the child and in the best interest of the community. So the question, Godfrey, is why aren't we doing that for all of sexual and reproductive health? Here, we get now to the bill itself. The bill proposes to reduce the age from 18 to 16. Only for sexual and reproductive health, not for signing contracts, not for buying property, just for sexual and reproductive health. Okay? Why 16? Why does the government choose 16? Well, it chooses 16 because at the moment, 16 is the age at which we can have lawful sex, at which sex is no longer a crime, would be the proper way to put it. So all that is doing is correcting a legal absurdity. The legal absurdity means that you can have sex at 16, but you can't have autonomous access to contraceptives until you're 18. Mm-hmm. I mean, come on. I am free to make my own decision about sex, but if I'm to get contraceptives, I have to get my parents' permission? Give me a break. That's nonsense. 7 other countries have already done this. 7 other countries in the Caribbean have already done this. Jamaica, my own country, did it in 1979, almost 50 years ago. But that is a waste of time. It does not address the problem. The real problem is the social reality that, practically a third of our teenagers are experiencing sex, voluntarily or otherwise, at age 15. Come on. What's the point of stopping down at 16? We need to get much, much lower to solve the problem. A lot of the noise initially about this bill and 12 years old, it was reducing the age of legal sex to 12. That does not change. Nothing in the bill changes the age at which sex is no longer a crime. Right. That remains 16. That's 16. If there's one thing that I would like us to be clear on, is that is the case. There is no change whatsoever in the age at which sex is no longer a crime. That remains 16. I want to share some cartoons with you, just last three slides. Here is a situation. Let me just give your viewers a chance to read this. Mm-hmm. So we think of consent Our knee-jerk reaction when you think of parental consent is to think of a perfect home, a flawless home, wonderful spiritual sense, wonderful responsibility. That's not the case with every home in Grenada. We have some terrible, terrible homes in Grenada. Some of them are pimping their children. Yeah. And that's not to make a moral judgment on the home. It is to say that we have extreme poverty and therefore the children are abused. And in some instances, even when the child is abused, the family says, hey, I am not going to report this because that will bring shame. Several of your panelists have mentioned the word stigma before. Mm-hmm. Stigma creates real problems. So this child is abused and is unable to report it because of parental consent. So parental consent actually turns out to be harmful in some circumstances. A wonderful thing in a good home, a dangerous thing in a sad, wretched home. Here we have another example of vulnerability and agency. The bill is not designed to take power away from parents or to take authority away from parents. It is designed to give agency to the vulnerable. Right. And that is what is depicted here. Right. Between a child who is in pain, is suffering, and she needs to know who to turn to. How do we do this? And this means we need to be educating, providing education at every level. And I think this is the last slide I'm going to share now. Here you have the problem. We're not educating the children in school. The Health and Family Life Education Program is very poor. And by the way, notice what we call it, Health and Family Life Education. We can't even use the word sex to describe the program. We can't call it comprehensive sexuality education, which is what it should be. But in the absence of an effective program, in the absence of parents discussing sex with their children, what you have is innocence, leading to ignorance, leading to vulnerability, and then to exploitation. That is the problem we're up against. And here you have a teacher saying, gee, this one good thing out of the ACR bill is, gee, it has provoked a turmoil, it has provoked a discussion, mm-hmm. and maybe some parents are taking it up. But what I would really like is for my principal to improve my resources and improve my time so that I can strengthen health and family life education. That's what I wanted to share, Godfrey. Mm-hmm. Let me stop sharing now, and then we can hopefully have some discussion, and I would prefer disagreement. That's wonderful if we have disagreement on this.
Mm-hmm. Yeah. No, this is really wonderful. And let me just ask Dr. Fred, if you can share these slides with me, I'll be very happy. They sure. can become very useful for program content, so I'd be happy if you can. But something you mentioned that I heard a lot, and I will hasten to say it came directly from the mouth of some politicians here in Grenada, that this bill was taking away parental rights, and I'm happy you raised it. And this is something I would like you and probably Dr. Fletcher and the others to speak a bit more on, because I think there is a serious lack of understanding, and in some cases an abuse of to gain political mileage on this issue, and I think it is wrong.
Yeah, unfortunately, very unfortunately, Godfrey, we have adopted, inherited, accepted an alien form of discourse, a Western form of discourse. Generations ago in Africa, we used to sit in a circle. We never had two sides. We would sit in a circle, we would have a talking stick, and we would talk and talk and talk until we arrived at a consensus. We have adopted this Western parliamentary madness, not of dialogue, but of debate. Mm-hmm. And so this is a win-lose situation. So if you are the government, I need to do everything fair and foul to upset you. So I will scream about teaching children to masturbate at age 4, which one person has actually said. I will scream about making it easy for predators. This is the exact opposite of what this law is doing. This law will improve reportage, which we do not have very well now. In fact, our director of public prosecution said, look, part of the problem he has is that sometimes parents are protecting the predators. Right? So they come to court and you can't get them to testify. We're talking about mothers and fathers doing this, right? So what adolescent who can then make their own representation. By the way, something which hasn't been spoken about at all is a story that Nkosha shared with me of a nurse who turned away, I don't know, let's just say a 14 or 15-year-old who was saying, look, I would like contraceptives. He said, look, lawfully I cannot give you contraceptives. That would endanger my license. I cannot lawfully do that. So she turned the child away. The next time she saw the child, she was pregnant. Right? So it liberates not just the children, but it liberates the healthcare providers. The idea that this law is taking power away from parents is weird. No parent who has an appropriate, willing relationship, trusting relationship with their children, no parent who has worked with their children and is interested in their children's maturation and growth has anything at all to fear from this law. The people who have to fear are those who are abusing their children or not taking care of them or not educating them. But it may well be that this very bill will encourage and foster discussions where there has been an abyss.
I agree. I totally agree. Dr. Fletcher, you want to come in here and, make any additions to what Fred spoke of?
Well, I think everything was so well said. But, back to that story that he was just giving, that was such an unfortunate case. And what happened, as you would imagine, based on the context in which Fred gave the story, the guardian, she said, go and bring the guardian. You can come back with the guardian and I'll give you contraceptives. That I'm allowed to do, like we said, by law. But it turned out that the guardian was a perpetrator.
Oh boy.
So here she is now, and I mean, this took a toll on her. Of course, that, like we're saying, is what we want to put an end to. That is what we want to stop from happening. Because with a bill like this young girl would have gotten her contraceptives. And of course, we would want her to report the incident entirely. Yeah. And that is what we'll foster. But I'm saying then, if we're using this very case, she would have gotten the contraceptive and not at 14 become pregnant. Right? But now we want to ensure that she's encouraged, she understands that she can now talk to someone, report what's happening, and have the perpetrator dealt with. Yes? Yeah. But I really do want persons to ask all the questions. I want us to dispel the confusion, the misconceptions, because that's what's happening here. I really think it's a case where we're not getting the correct information out there. And of course, with the incorrect information that's being passed around, I can understand the anger and the frustration. But once we sit down and we really make sense of this, I think it will change everything entirely.
No, I do believe that. And I think, all it requires is a little thought, not a lot.
Yeah,
Not
exactly.
a lot, a little thought, and I think this whole thing will be cleared. The story that you related regarding the 14-year-old.
Yes.
I mean, I it was a step in the right direction because questions could have been asked.
Right.
Why at 14 you need contraception? And it was that question could have opened up the door for a lot of what was happening.
Correct.
Correct. So you can look at it from different angles, and there is so much that can come out of it. And I think a lot more awareness needs to be raised. In fact, we may have to do a part 2 of this because I don't know if you realize, because we're almost out of time.
Right.
So we may have to do a part 2 of this to get this thing well fleshed out, because I think it's important that people understand that bill, because there's still a lot of misunderstandings with all that has been bandied about, especially from people who are supposed to be leading and providing guidance. So I think we do have a responsibility here, to put that information out there and get people to understand it so that, they're on the right track. Mm-hmm. So let's bring in the young people before we wrap, at least just to have their say on the bill. Zarika, we can start with you. Your thoughts on the bill and how we can actually help quickly.
I think the bill is a great initiative because it gives access to adolescents at a young age. Access, because a lot of adolescents may feel... A lot of adolescents might be scared or might not have anyone to talk to. So I think this is great, and it gives access to them to have the right services and yes.
Yeah, protect themselves. Yeah.
Yes, protect themselves.
Yeah.
Okay, so my opinions on the bill somewhat mostly align with Mr. Fred Noon's here, because a lot of the points he made, I feel like they're really good points to bring up when discussing it with someone, especially a lot of people who may be ignorant or so, because as GPP, I'm going out in the street, and so like I told y'all, interacting with people and talking about it, we've heard a mix of opinions on it. So I feel like this session especially has been really great with coming forward with points and so on that.
Right. Eloise, your take?
Well, my take on the amendment to the bill. Firstly, I believe that I want to point out that the focus of the bill is not only solely on contraception and STI testing, but it covers a vast majority of the not the vast majority, I'm sorry, it covers a wide range of other diagnostic tests that young people don't have access to right now, like even regular checkups for just like irregular menstrual cycles and stuff like that. It would give young people access to all of those things as well, not just as people would say, the freedom to go be full stripe or fast. That's not what it's about. And like I always like to say, prevention is better than cure, and we all know that the only surefire way for prevention is abstinence, but we cannot ignore the fact that we live in a society where we have normal bodily functions. We are all human beings, and things will happen, and we have to have avenues and systems in place that act as methods of prevention and protection. And I feel like the bill is going to be a really great avenue for that mantra: prevention is better than cure.
Right. Yes, indeed. So, as I said, I would like us to continue, and we can communicate, Dr. Fletcher, during the course of the week and see how that can proceed. Because there are a couple of things that also comes to mind as it relates to what is happening. And Frank did mention about the behavior of some parents, how they use their children. And immediately the issue of economic status comes into play. Are these people able to take care of themselves? And so they need an avenue, and children being vulnerable, they it's there. So there's so much to talk about that I think it requires another program. So Frank, sure. Mm-hmm.
Let me just throw something out which I think is very important. The bill had a peculiar clause in it where it mentioned, if there is good cause, we will reduce the age to 12. Mm-hmm. Which is a very peculiar thing. I've never seen a bill which says we may do something in the future. Bills are usually for what we're going to do now.
Yes. Mm-hmm.
It's a very peculiar thing which I don't understand. I'm not a legal draftsperson, so I can't say. However, that was taken completely out of context. The process that it said was, look, if we are to do this, if we find the cause, satisfactory cause, we will do this. But the process was, we have to take it back to Parliament. We have to have a positive vote, not a negative vote. We have to have a majority vote. So that was used to create hysteria, to create alarm, and to really put fear in the people. Mm-hmm. The other thing I want to mention is a word that I heard Nkosha use right when I started on. The word was trust. To go back to that 14-year-old situation, if that young lady made the decision, I'm being abused, and it suits me to take the contraceptives and tolerate the abuse, she may eventually find the courage to do the reportage. Mm-hmm. We can solve the reportage. Doesn't always or necessarily mean report to the police. Mm-hmm. It could mean report to social services. Could mean sharing the information with a non-governmental organization.
Somebody she trusts.
Getting help. But unless the healthcare worker has the license to meet with this young lady, there is no opportunity for building that trust.
Mm-hmm, mm-hmm, mm-hmm. Definitely. So while you're at it, Frank, I'll give you 30 seconds just to maybe make some closing remarks, and then we'll go to Dr. Fletcher and wrap for this evening.
Thank you very much, Godfrey. I think the key thing now is for the government to move with the bill with some conviction. And there are many ways in which it can do this. My own bias would be for the government to move formally towards a joint select committee, which is a structured way of ensuring that we get the best input from religious groups, from parents, from advocates, from adversaries. Get those things into a select committee and have the select committee labor over it and return a bill to Parliament. This would mean acting quickly because normally you would move to the second reading. This would have to be done before the second reading.
Yes. Indeed.
That would be my big wish.
Yeah. Yes. Okay, thank you very much. Dr. Fletcher, your closing, final words?
Yes, again, just to sum up, I mean, we started with the BBE and what projects were being done, and then we went into lots, and then it almost seems like we needed we needed 3 sessions, we needed 3 programs. Mm-hmm. But I agree. I think joint effort. Let us come together. Let us get this done. Let's make the change. And let's improve the lives of the vulnerable children. And there are many. I'm sitting here and I'm thinking of children that I've dealt with. And it is real because, like you just said, the economic status of a lot of these persons, it's a case where the 10 and 11 and 12-year-old children are forced to do things to provide for their siblings and themselves. So we have a problem on our hands that we need to get on top of. And I think that joint effort, the joint effort, one, and two, really having persons, again, to reiterate, understand the need for this change.
Yes, indeed. I agree.
This is what we need here.
Right, yeah. And, our platform is available. This is the one way we can, seriously, contribute to the issues, making the platform available so that we can get the word out there so, the process can start. I'm really happy that, you reached out to be in the program to have the discussion, and I think it has to continue. So thank you to Eloise, thank you to Jodelle, thank you Zerika, Frank, thank you so very Fred, sorry, I've been having your name all over the place.
Not to worry, my friend.
Yes.
I will accept any name.
Yes, indeed. And of course, Dr. Fletcher, thank you all so very much for being here. And
excuse me, before we end, I just want to state that you can follow our Instagram page and Facebook. We'll have a PTA meeting and also a LARC session in Bel Air Government School in Grenada. So you can follow our Instagram page and you'll get further information on those upcoming sessions. And thank you to all the sponsors.
Thank you very much, Sarika.
Thank you for having us.
It was indeed a pleasure, and I look forward to having you guys very soon again. So we'll have some conversations, and then we'll arrange for a part 2 of this. So thank you very much, everyone. It was indeed a pleasure, and we look forward to having you on the program very soon. All the best, and do have a good night.
Thank you.
Yes. Yes.
Thank you. Have a good night.
Yes. Thank you very much.
Thank you.
Yes. Grenada Planned Parenthood Association for being on the program with us, and we're looking forward to having them pretty soon again. Thank you very much. Join us tomorrow evening 8:30 for our Kaiso Talk. We look back at the recent Hubbard's Legends in Concert, and of course, as we go on, we will be infusing a little parang here and there. So thank you very much, and do have a good night. All the best.